Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by Carium, the telehealth platform enabling healthcare's digital transformation, helping you care for people within the fabric of their daily lives. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Dr. Matthew Lambert, Chief Medical Officer at Curation Health. Welcome, Dr. Lambert.
Thank you so much for having me, Matt.
So what I always like to do before diving into the main part of the conversation is to give my guest a chance to provide more of an introduction in terms of who they are and what they do. So the floor is yours.
Fantastic. Thank you. Again, my name is Matt Lambert. My title is the Chief Medical CMO for Curation Health. But before that, I'm an ER doctor by background, clinician, still practice part-time. It's challenging days for practicing, especially in the emergency department. But everything I do comes from that. Based out of DC. And over 10 years ago, we started a firm called Clinovations, which was around the time the Affordable Care Act and the Meaningful Use Bill all came together. A group of physicians, clinicians, we decided we were going to inject as much clinical influence into these changes as we could. And that led to us growing our firm called Clinovations, and we wound up being part of the advisory board for a while before it went to Optum. And that led for CMIO opportunities all around the country, helping health systems implement, configure, and drive value from electronic health records. And that got us into along the way, we got into the HCC space, ways to capture the currency of value-based care. And we had a tool that was developed and part of our offering at Clinovations and at the advisory board, and actually is now the Optum offering. And when Kevin Colleton, our CEO at Curation Health, we decided to restart that, we built on those lessons learned with Curation Health. And we really helped providers and provider organizations make the transition to value-based care by helping decode the complex regulations around it, particularly around HCC codings and documentation around it.
Yeah, so kind of as you said, you're a physician by training, and it sounds like still some amount of time. So what kind of inspired you to transition from what might have been full-time clinical practice before into this advisory side? Yeah,
I wish I could say it was all perfectly planned and flawlessly executed, but needed after 10 years of a dedicated clinical career, needed to diversify. Both for personal and professional reasons. And then I got into my old med school roommate, actually Trenner Williams was the founder of Clinovations and is now with his firm called Socially Determined. And Trenner saw this coming and saw the need for clinical influence into this, into technology adoption in the healthcare space. And it's just grown from there. 10 years ago, if you would have told me that I would be doing a position like this now, I would have thought, no way. Strangely, it's allowed me to, I feel like I'm practicing medicine at scale with technology. And I also feel like I'm helping my physician colleagues adapt new technology and new ways that benefit patients. And at the end of the day, we're trying to push new levers to get better outcomes at a more effective, better price point, right? And I enjoy the practice of medicine now more than I ever did now that I do it part-time. Emergency medicine lends itself to that. Do it on weekends, do it on holidays, when the business or government world isn't working, and it's pretty flexible that way. So it's certainly wasn't planned, but very welcomed, and it's been a remarkable journey.
And I think kind of one of the points you just made of being able to help influence technology so it makes the practice of medicine better and enhanced is a perspective that I think is advanced a lot, but not necessarily actually, you don't necessarily see the follow through on it. So what are you doing to help make it so technology is actually starting to fulfill the promise that it keeps being attached to it?
Yeah. It's, we don't, you don't fail in this space. You only iterate, right? And you have to have that's a certain mindset that clinicians don't necessarily have. Sometimes there's only one opportunity to do something, especially when you're doing acute care. But in healthcare and technology, there's always an opportunity to learn and to build. The other thing, it's a little cheeky, but I'll go ahead and throw it out there. When I put on my chief medical information officer hat, whether that be at a health system level, I only had two answers. One was no, and the other was keep it simple. And I think focusing on how do we leverage technology to make things better for providers and patients, and keep it simple and iterate on that as you go. I think is the key to that. This was guided for a long time by meaningful use requirements. Now that we don't have that, we're a little more freed up to improve and iterate based on experience and based on what we're seeing, what the market's telling us, as opposed to what the incentives were telling us around. And for all the good the Meaningful Use program did, it really got us into this space, but now it's up to us to continuously improve on it.
And is it fair to say, as you just said, with meaningful use no longer providing maybe some artificial guardrails around how the technology should operate, is the market that you're looking at, the value-based care market, and if that is accurate, what aspects within value-based care are helping to drive the enhancements?
Yeah, it's clear the tools that most of our provider partners are trying to use, it's clear they're not value-based care tools, right? It's clear they're fee-for-service tools. So one of the sources of frustration, one of the sources of market inertia is we're asking providers to do something they weren't trained to do, right? They're trained to in a fee-for-service world and trained to document in an E&M code world. And the tools that they've been given are fee-for-service tools. So it's to help adapt that technology and adapt that workflow to a new process is really a lot of what we do. And we wrangle a lot of data in a way that a health system can't. They can't support a software development team or a team of analysts to help do that. And the APIs market has finally matured enough to where we can really integrate in a meaningful way to help providers do this. And the technology investments, as much as they were, didn't necessarily keep up with M&A. So if, when you think of a system that's really growing or a system that's on disparate EMRs, they're still kind of flying blind when you think about at a population level. And so one of the things we try to do at Curation Health, aside from making it easy for providers to document in a way that gets them credit for the complexity of their managing, but we also help provider organizations see almost as if we were the middleware, organizing their data in a way that's actionable.
And actually, you just mentioned something that I think you had also alluded to at the beginning, which is the appropriate coding and documentation from the physicians and other clinicians to make sure that they're getting the appropriate reimbursement. And hopefully I'm remembering it correctly, but I think you referenced it as HCC earlier. Yeah. So can you unpack what that means a little bit? Because I suspect people have heard about it, but maybe don't necessarily know the mechanics or the details.
Yeah, and I'm going deep here. So the ICD-10 codes are what providers are used to working in. They're diagnosis level codes. There are 65,000 of them, and providers never signed up to be data managers, but sometimes at our worst, that's what we're asking them to do. Now, out of those 65,000 ICD-10 codes, those map to 86 HCC codes. The HCC model was developed in 2004. It's on version 24 now. Expect version 25 out sometime soon, but the cadence of things coming out of Washington this year has been all thrown off, for obvious reasons. But these 86 HCC codes group diseases into a category that help predict cost and utilization. So when you think of essentially a risk model or a more advanced a model of, when insurance companies used to do this sort of thing, it was basically based on age and gender, right? But now we've got the technology to bring in certain conditions that really drive a lot of cost and utilization. So these HCC codes are the currency of value-based care, and it's an entirely new way of documenting, an entirely new way of thinking for provider organizations. The CMS payers use them to, again, predict cost and utilization. So if you're not speaking the same language, you're not getting credit for managing the complexity that you're really managing. And that's usually the best way it lands on providers. Say, look, you're taking care of a really complex patient. Or if you're a financial organization, you're assuming financial risk for a really complex patient. Be sure that you are capturing that, and your reimbursement will reflect the work that you're doing. And I guess I'll wrap it up by saying it's not how ill your population is. It's how well you document how ill your population is. And that's not the way the providers are taught to think. And so we try to make it easy for them through education and through technology, make it easy for that to happen.
So is it fair to say that a primary goal of the HCC coding is to have a more accurate and granular picture of the overall health of the entire patient population that a clinician is serving?
Yeah, absolutely. And again, they've developed and iterated up to version 24 now of ways to get it more and more accurate and more truly reflective of that. It's a good guard against patient selection, right? I mean, if we're talking about going at risk for patient populations, you're going to select the healthy patients and not want to enroll the sicker members, right? So the HCC coding allows you to really truly reflect the complexity of the patients and to get reimbursed for assuming that risk for a sick patient. So that's the one side of the coin. Is it's a anti-selection method. The other, and I just look at this at this came about in 2004, right when Medicare Advantage was really starting, and because the private insurers, the commercial insurers, wanted to grow, and there's only a certain based population where they can go to your employer and provide health insurance for you. So when they decided to go into that 65 and older market and provide Medicare type services, quite frankly, one of the things they said is we'd love to move into the space. We're going to have to market directly to these patients instead of marketing to the head of HR at, let's say, Ford Motor Company, right? But we are going to have to find a way to measure that extra risk to do this. And full disclosure, I mean, the payers said we can't manage these patients for the cost that the federal government can't. And the Medicare or the HCC coding is the way to express that extra risk and get reimbursed based upon that.
Kind of picking up on that, as you said, if the HCC coding helps to drive what the reimbursement is there, hopefully not making it overly simplistic, but a sliding scale of reimbursement. So for the healthier end, the reimbursement might be lower. And then as you keep going up the acuity scale, then the reimbursement probably doesn't necessarily increase as fast as the payers might hope for, but it's still increasing.
Yes. Yeah, it is. And it's also the model. It's been fascinating to watch the model evolve. It started out with, the dirty dozen, I like to call it, the things that, you see in every population: diabetes, hypertension, obesity, high cholesterol. And then it's evolved over time to include more things that you might see from someone in a personal care home. So we would think of, folks who are disabled with strokes. And it's even really made a big pivot here in the last couple of years they don't collect a lot of social data on patients, but they've figured out ways within the clinical diagnoses in the HCC model to assume a lot of the costs that are associated with social challenges. So the last couple of years, you've seen additional codes in behavioral health. You've seen additional codes in substance abuse, particularly around the opioid epidemic. So it's going to be interesting to see where COVID fits into this a year down the road. We just added the coronavirus ICD-10 code. So, the U code where you can put that, but I don't know where that's going to fit in with the other risk model. I think it depends on how long we're in this current pandemic situation to do that. But it's evolved. It's evolved and continuing to evolve. And as you say, always not quite fast enough for the payers. But it's certainly moving faster than a lot of the provider organizations are moving.
Yeah, and kind of as you said, that the key always is that there's going to be evolution and change over time. And for those of you just joining, I'm talking with Dr. Matthew Lambert from Curation Health, and talking about the influence of technology on the change from fee-for-service to value-based care, and more granularity and specificity with coding. And kind of what we've just been talking about is the Medicare Advantage program. And as you were just saying, it's when the private payers were getting into it, you said they wanted to be able to figure out a way to be more accurate, so that way they can figure out how do you gauge a premium on top of what Medicare might have, because I think you very well stated it, the private industry just can't afford to operate the same dollar levels as the government might. So how has Medicare Advantage become such a popular program? Because I feel like when I'm reading about it, it's one of the biggest profit centers for insurance companies. So how has that evolved? And is that kind of a success story for value-based care that maybe that angle isn't touted as much as it could be?
Yeah. Let's see. I'm going to get political because I'm here in D.C. and I'm 7 blocks from the White House. Medicare Advantage came about during the Bush years and grew there. There was a lot of chatter, I'll say, during the Obama years that they might draw back some of the Medicare Advantage markets. And then, of course, Trump would tweet about how great the Medicare Advantage plans were. So who knows what's going to happen with the incoming administration now around that. It's a good value for members, for Medicare members who enroll in this. They do see extra benefits. It is a windfall for the payers. They are able to get reimbursed for what they see is fitting for the level of risk that they're taking on with an aging population, right? And when patients get into their spending years, for sure, when it comes into healthcare. Some of the things that the flaws, I'll call it, or things that we can do better in Medicare Advantage is it still costs you and I more to support our senior members. It by definition, it costs more for the taxpayer to take care of a Medicare Advantage a patient than it does a fee-for-service, a standard Medicare patient. That's just a fact. It also, I would really like to see more sharing amongst the provider organizations, right? We're asking the provider organizations to behave differently. We're asking physicians to code differently and behave differently. But very often that is the shared upside from a Medicare Advantage patient isn't really shared equally with the provider market. So I would love to see a correction there. And the payers are always ahead of the providers. Just they're more nimble. They're more farther looking. So as more and more the provider organizations really learn about the balance sheet, I think they're moving in that way. But those are the two things that I'd like to see improve upon it the most as we move forward.
Yeah, and kind of as you're talking about, the popularity of the program and the benefits, what do you see as some of the factors that are causing, the benefits or causing the improved benefits or potentially the improved outcomes for the beneficiaries who've chosen Medicare Advantage over traditional Medicare?
Yeah, it's always good to pull it back to outcomes, right? I mean, we're talking about a lot of different things other than how well patients do, right? So I think there are when you compare regular Medicare versus Medicare Advantage, there are a lot of incentives for wellness, a lot of incentives for improved diet, a lot of help in guidance on what's the most appropriate level of care, right? Let's make sure, it's obviously Medicare enrollment season. Anytime you turn on the television between October and December, right? Sometimes it can be overwhelming with the number of commercials you're seeing to enroll in a Medicare Advantage plans. But it's also they have some extra incentives that help patients do well and help patients stay healthy. And really, that's what we're trying to do. And Medicare just can't, as a government payer, just really doesn't support a lot of that stuff.
Yeah, and arguably, the government as the Medicare payer. Not only does it not have the resources, it doesn't have the incentive to want to do it because it's just there. Whereas, as you were just referencing, given, during the open enrollment season, you've got the different Medicare Advantage plans competing with each other for the patient population. So they do need to figure out ways to distinguish themselves, which kind of brings you to a more theoretically consumer-oriented market.
Correct. And we, and that's how that's how folks are used to consuming other resources in their lives. And that's how they've been used to focusing or consuming healthcare resources throughout their commercial payer days. So I think it is a very comforting spot or a welcoming spot for a lot of seniors to enroll in a Medicare Advantage plan. Again, there's no such thing as a free lunch, though, right? And that resources come from somewhere, and it comes from the government funds and taxpayer support for sure.
Yeah, and kind of as you're saying, given that support and given the fact that, if reports often suggest that there is a good amount of profit, maybe two questions where there's probably not a clear-cut answer, but, I think one question is, as you were suggesting, should those profits be better split between the payers and the care delivery organizations that are actually helping the payers succeed in the program? Or does that mean that despite, industry complaints, maybe the payments have been adjusted up too much and could argue for, potential cuts in funding to the program?
Yeah, it's a pretty good vehicle for transferring private money into shareholder hands. It really is, and I think just like any piece, it needs to be monitored and it needs to be corrected, and that's the role of the regulators to do that. It's when you see some of there's been some cases where there's been some fraud involved with this, but when you look at those are really pretty egregious and quickly corrected. And I think everyone knows where the lines are of what you can do around this now. It's interesting, though. It's the other side when you think of like the ACO market that has a cap. So if we're really trying to incentivize value-based care, it's going to happen through Medicare Advantage because there's not the cap on it that there is on some ACO plans. So, and at the end of the day, let's kind of step off of Medicare Advantage and the reimbursement model. But really what we're trying to do is not pay for this by the unit and pay for the outcomes, right? And it really incentivizes provider groups to provide sometimes high touch care to their patients, sometimes with, a care manager as opposed to a physician. And it also really puts a big management on data sharing, or a big emphasis on data sharing and on care management. So if we can get the same clinical outcome out of a text message to a patient to remind them to take their blood pressure medicine, then why are we doing a visit? Why are we having you take a day away, come down to the office, or even do a video visit? If we can get the same outcome using technology and care management. So that's a really big shift when we think about fee-for-service world versus value-based care world. But that's really what we're trying to do. And I think, coronavirus has got me questioning everything about what we do in healthcare and what really affects the most outcomes. So hopefully we can come out of this with some new insights and new incentives to keep pushing us this way, because I think it incentivizes people to try new things that'll work better and be more efficient.
Yeah, and I think that level setting is an important transition point because, as you said, you can use Medicare Advantage as a stepping stone and introduction to a broader value-based care world. So, do you get a sense that is actually happening? And maybe if it hasn't happened as much as desired, what could be done to help further that goal?
Yeah, well, almost half of all patients Medicare eligible are involved in a Medicare Advantage plan now, so it's moved a lot. And I don't see anything. Again, we'll see how what the incoming administration wants to do with this, but I don't see anything short term that's going to stop that trend. The biggest thing that's the biggest market inertia to adjusting that is just a model that's based on how many patients did you see in the clinic today, and how many procedures did you do? And and that was the big thing too about March and April this year, when patients stayed away. We went completely to telephone or telemedicine visits, and we canceled elective procedures, which are the two biggest drivers for any health system. Their elective surgeries and their ambulatory visits. So we're going to get a whole new look at a data set of what healthcare cost and outcomes look like when we take away the two biggest things that are holding us back from shifting. And this is all because, again, a heads and beds model and a fee-for-service model, it requires the CFO to think 18 months out for their reimbursement and as opposed to how are we paying our bills this month. And that's the biggest thing. So I think more incentives. I hate to be the supply guy, side economist here, but I think if further incentives to go to value-based care are going to work better than anything else, because those organizations need it to get there.
Yeah, and I think you're right that being able to gather unintentionally all the data because of COVID will hopefully drive that, because I think the frequency of the comments is slackened off a little bit, but certainly through the summer of COVID, there were so many statements of this is going to be the final turning point to get physician practices at least into value-based care, because as you said, when all of a sudden you turned off the patient spigot because everyone was told don't come in, or there's just no ability to access. In a fee-for-service world, that means also the money spigot turns off because you're not providing services. But if you're in value-based care, now kind of picking up on what you said, you have the incentive to engage remotely because it's been, I think, hopefully proven out now that a lot of stuff can be managed that way. Yep. And a lot more efficiently. And if you're doing that, you're still getting the dollars in the door because you're dealing with a set amount per patient and measuring against that, where, I think, as you've already been implying, the incentive is to keep a focus on health as opposed to, addressing issue by issue.
Correct. Yeah. Make it, again, it's so cliched, but, volume to value, right? Let's not incentivize volume of care, which is what health systems have done for a long time, and they're still really kind of doing, some of them, right? M&A is more aggressive than ever, and health system consolidation. But what do we do if we incentivize value? Now, I think this year, or actually next year, is going to be a big tell. when we say, I don't know about you, but my insurance company didn't charge me any less this year for my monthly premiums, and my mortgage company kept charging me the same amount all year long. So the Medicare Advantage plans are in a pretty good financial position right now. Now let's see what that looks like next year, as far as the extra money and fewer services that they provided this year. I think we're going to see some increased costs and utilizations from folks getting sicker because they delayed certain parts of their care, and I think we're going to see a certain amount of that. But it's that I think is going to be. I think just judging on this year alone isn't going to be enough to say what the future is going to look like for value-based care. I think we need to get a reading on this year and a reading on next.
And I think that's a pretty good reminder, because as you said, it's you wouldn't want to base a change off of irregular data. You need to figure out how it fits into a broader pattern, and also, frankly, probably the first quarter of 2021 is going to be completely skewed, because who knows how long a surge is going to be, or what the final impact of a vaccine could be as that starts getting rolled out to the broader population.
Yeah, I would brace for Q1 being the worst that we're going to see yet, and not just clinically. We're seeing more coronavirus than ever, but we haven't seen wide scale cancellation of elective procedures, although it's starting to pop up in pockets, and patients their own anxiety is not keeping them away like it was before. So it's busier than ever, and I think Q1 is going to be really challenging. And I would really encourage a MA plan or anyone with risk to. You can still do a telehealth visit over FaceTime, right? That's how much deregulation there was in the spring, and so typically value-based care plans try to get as much of those comprehensive visits as they can early in the year, so they can capture most of that complexity. And so I would really encourage patients and providers to engage via FaceTime or Zoom, whatever the case may be, in Q1, to set that baseline and to find out how care is going to evolve throughout the year. Because I think Q1 is going to look a whole lot different than Q4 in a lot of different ways in 2021.
Yeah, no, and I think that's a good point and a good reminder of, just because it's a unique situation, you still have to remember some of the basics and the fundamental parts of it, and how to be able to deliver it. But believe it or not, we're already out of time. So I want to thank my guest, Matt Lambert, for a great conversation today.
Thank you so much for having me.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.